Good morning, everybody, and welcome to our session on examples of good practice within Hywel Dda Health Board. We're going to try and aim to provide you with a snapshot of some of the innovative services delivered by Hywel Dda Health Board. There are many that we can talk about, but we've just picked a few, and there's some information on our poster displays as well. So we're going to cover very briefly our local primary mental health support services, our Fire Mental Health Action Partnership, our Cwmseren Recovery and Rehabilitation Unit, Early Intervention in Psychosis Services, our Therapeutic Day Services, and our Veterans Health and Wellbeing Service. As Trevor says, there will be an opportunity at the end of the presentation for some of our colleagues who we've brought with us who work specifically within these services to answer any of your specific questions. So the local primary mental health support services was developed in 2012 to deliver part one of the Mental Health Wales measure as detailed within the regional scheme for Carmarthenshire, Pembrokeshire and Ceredigion. These services were designed to build on our existing primary care services within each of the counties and to build on our existing primary care CAM services within Hywel Dda also. The service is managed regionally and delivered locally in order to ensure that we deliver a consistent approach across the Hywel Dda area. So the philosophy of the local primary mental health support service is about providing a service that is based around strengths rather than problem-based. It's about working in collaboration. We've talked a lot about partnership this morning already. And the service is very much based on working collaboratively with the patient and their families and other services. And it's a key focus in delivering these services in order for individuals to have access to a range of services within their communities to meet their needs. Part one of the Mental Health Wales measure defines the key roles of the local primary mental health support services, the provision of a comprehensive mental health assessment within 28 days of referral, to provide a range of mental health primary care treatments and interventions, signposting on as appropriate to a range of services based on the needs of the individual, to provide information and advice and assistance for patients and carers across all age groups, and to provide information, advice, support and training for primary care providers, GPs and other practice staff. The local primary mental health support services is built on a cognitive behavioural model of delivery, and the service provides a range of interventions, and there's just a list there of some of the services and interventions that are provided within Hywel Dda within a range of venues. There is an agreed data set within which to report activity and compliance with Part 1 of the measure to Welsh Government. There are also agreed processes to ensure that outcomes from treatments and interventions are recorded and reviewed. Standardised feedback systems are in place to capture patient and primary care staff experience of our services, and there are clinical supervisors employed within the local primary mental health support services to ensure that clinical effectiveness is central to the service delivery. Leslie Harvey, who's there in the audience, is our regional lead for our local primary mental health support services for Hywel Dda, and she is available today whether over lunch or during break or to take questions at the end if you have any specific questions. So moving on very quickly then to our Fire Mental Health Action Partnership. This was established in 2010 with a targeted role aimed at reducing the risk of injury or death from fire for individuals experiencing enduring mental health problems. Initially set up as a 12-month secondment as part of a 3-year project plan, the project has examined the available evidence related to mental health, vulnerability and risk of fire, and has identified that up to 90% of death or injury from fire is linked to mental health issues. And some of the evidence there is listed for you and available. The research has identified key vulnerability factors that increase the risk of injury and death from fire in this client group, and a range of those is listed there through from medication, alcohol, smoking, and a variety of other issues. So what does the scheme deliver? All patients who are known to secondary mental health services are referred for a home fire safety check. Where access is difficult for the fire service and good relationships exist with health workers, they will complete a health fire safety check on behalf of the fire service and report that information back into the fire service. Staff will share key risk and vulnerability factors with the fire service so that on their database, when a 999 call is received, that information is available. There have been a number of challenges in establishing the project. I won't focus in on many of them. It just gives you some idea of the volume of the large number of clients that we're talking about, over 3,000. And we know that we've had poor engagement from some client groups, hence really the focus of the project. Some challenges around staff's perceptions of their core roles and taking on the role within their core responsibilities. And some positives as well. The project has improved relationships between the fire service and health and social care practitioners. Comprehensive training and support is provided to our staff by the fire service. They've also provided us with electronic tablet devices so that the home fire safety check can be completed by the health staff and electronically sent through to the fire service. The scheme now is also being rolled out within substance, CAMS, elderly, learning disabilities and chronic conditions, and it is in fact the first project of its kind in the United Kingdom. Alison Evans, wave, is our partnerships lead and has led on this work, and again she's available if you want to speak to her directly. And finally from me then, before I pass on to you, Anne, just a little bit of an overview about our rehab and recovery unit. Pardon? 35 seconds, all right, okay. I don't know whether to talk or dance. Okay, so we've got some key information there just about the unit. I won't tell you too much about the unit. If we move on to talk a bit about the philosophy of the unit, the focus is very much about allowing individuals to be provided with care closer to their homes and their care teams. And we've worked over a number of years to repatriate a significant amount of individuals from external placements outside of Wales so as they can engage with their care teams closer to home. The service provides a whole range of interventions, and the team is multidisciplinary with access to a range of services and interventions across our mental health services and with our partner agencies to optimise recovery and rehabilitation into their own communities. In terms of the aims and objectives, the focus is very much about individualised care and treatment for adults with serious mental illness in a safe and supported environment, very much focused around helping individuals to learn the necessary skills to move to a less secure and supported environment. The focus of care programmes is on the individual's goals to return to an appropriate level of care within their local communities. Again, we'll skip over that one. So collaboration, there are a number of organisations and services that Rehab and Recovery Service collaborates with. I wanted, as an example, just to tell you about a supported living scheme that was commissioned in Pembrokeshire with us about 18 months ago in partnership with our 3 local authorities provided by Hafal. And this was to provide an intensive 24-hour support housing supported project for individuals moving on from the rehab and recovery unit or returning directly into the community from out of area placements. The success of this scheme run by Hafal has led to now further development and duplicate schemes being considered in both Ceredigion and Carmarthenshire, and I think that's a true example of partnership working towards recovery. Again, we've got Andrew Humphrey, who is our site manager, who manages our rehab and recovery service and our PICU services, and he's available as well if you've got any specifics, because I know probably haven't done it justice, Andrew. Sorry. Okay, hand over to you, Ewan.
Hiya, right, lovely. My name's Ewan, and I've got 5 minutes to do what Libby just did in 9 minutes 55 seconds. So I'll do my best, really. Initially, when we put this presentation together, we did actually have a bit more time. It's not bad planning on our part. Obviously, we've condensed this a bit. Sorry, I just knocked that, but quite a few people have done that as well, so should be right with that. I'm here to talk about the therapy-based services. Early interventions is the service that I'm the clinical lead for with psychosis, and it's one of the Welsh government intelligent targets, and there should be an early intervention service in each of the local health boards in Wales. There's two. There's one here, and there's one in Aneurin and Bevan. North Wales have a sort of a developing service, as the Swansea, Cardiff, and some of the other areas as well, actually. We run on a hub and spoke model, and those are basically the ideas that we're trying to do. We're trying to prevent the development or emergence of psychosis. We do offer, as Ron was saying earlier, a sort of a biopsychosocial model, but there we are. Not that we invented it. Obviously, it goes back a long time more than we do. And a point I'd like to just concur is what Angie mentioned this morning, is one of the things we'd like to do is work really, really closely with service users and their families, and we like to be away from the core secondary care service as a sort of a shop front thing, really. We can't do that as much in Wales because we don't have the infrastructure to, but we actually work in primary and also in secondary care. Sorry. That's the Welsh full target diagram, so we will be audited in April next year to see whether or not we actually achieve our aims. My time has now gone off, so I'm completely talking in the dark. It's like a nightmare. But there we are. We've also developed a revised pathway for psychosis across the health board, which I also think is probably one of the first ones in Wales, and it covers established psychosis and early psychosis. And the idea is that we actually try to introduce the same level of intervention to people who've got a more long-term condition, really, because the research shows that once people leave early interventions and go back to treatment as usual, they have a tendency to crash and probably 80% relapse in the first year, give or take. So we're trying to prevent that. Sorry, I'm talking really quick. That is the pathway. We will be over there at lunchtime, so I'm more than happy to discuss it with you. And I put points on each of the areas, and actually in the pathway thing itself, we say what people should be receiving under that bit. Lovely. That's the pathway for established psychosis. And also, one of our aims is to find people with an at-risk mental state. At-risk mental states are predominantly youngsters, but can go up to 24, who are having pre-psychotic symptoms. And if we can get them early enough, we've got a very good chance of actually not letting them transition into a full-blown early onset psychosis. Okay, I'm also going to talk about the therapeutic day services across the 3 counties very quickly. Basically, it's a service that was developed on direct feedback we received from service users, basically saying there wasn't a service out there for these people, so we thought, what a good idea, why don't we develop such a service? So that's what happened. That's the... Oh, this is the acute care service. You can't get your personnel, can you? It's ridiculous, you know what I mean? But there we are. Obviously, it works with crisis resolution, home treatment. It works with inpatient services. Primary focus is to provide evidence-based interventions to a client group that may or didn't actually receive these interventions. It's a new service, it's quite nice. We're now presently trying to roll it across the 3 counties of the health board. Let's go. Operates at 8:30 to 8 p.m. Take referrals, as I said, from community, crisis, inpatients, etc., etc. The thing I really want to focus on briefly in this bit would be the slides where we've got some qualitative feedback from people who actually use the services. There was an audit was carried out with patients who've been through the service, and basically the next slide says that quite a large proportion of people found it helpful, met their needs, recommended to friends or similar, 100% satisfied, 100% said the quality of the service was good. Next slide are some people's own words, basically. Very good, improved my confidence, wish it'd been available earlier in my illness, etc. Couldn't cope with everyday life, but during the sessions I found it very supportive. Good stuff, in other words. Let's go. Also, we run a All Wales Veteran Health Wellbeing Service. I'm running out of time, aren't I, drastically, really? This is, you know. I've got another 5 slides, believe it or not, and I can probably do them in 30 seconds. Right. I can't really, but the person who runs the service is here, and she'll be sitting, waving, and she'll be standing with us at lunchtime. I do apologise, but there we are. Yeah, I'm going to be told to leave in a minute. We've got 15 minutes, but it's a hub and spoke. Again, they're positioned. Let's go on. each area of Wales actually has one of these services. It's for veterans or people who've been in the army, etc., who have psychological difficulties because of what's actually happened to them in the army. And then the idea is that we actually offer them psychological interventions and therapy to enable them to actually, well, live, thrive and survive, really. Here we go. These are the aims of the service: to improve the mental health and well-being of veterans, obviously, because it's a veteran service, and to develop sustainable, accessible and effective services that meet their needs. The role of the community veterans therapist is basically just to do it. There's one of them, and she does lots and lots of good stuff, and she also provides therapy. Yeah, she networks, she teaches people, she promotes the service. We actually had a talk yesterday to GPs where she spoke about the service, and it's all jolly, it is good stuff. Yep. Yo! Veterans of the army. Yeah. Yeah. So veterans of all of it. No. I think the photos are army, but across the board. Yeah. Basically, that's the service remit. It's offer an assessment. Once the assessment's done, it's to direct people into the correct therapy that's actually going to help them. Next. That's the psychological therapy that's offered. We've got EMDR, eye movement, desensitization, reprocessing. We've got CBT, and I'm thinking TF-CBT is trauma-focused CBT. It's on a non-urgent basis, and the treatment is aimed at service-related mental health problems. Next. Those are the caveats of the service. Complex needs as defined as risks, depression, serious mental illness, drug alcohol dependency, dementia, neurological problems, and care and treatment plans. So basically across the whole gamut of problems people can have. That's us, we finished. I've been Ewan Hales. This is Libby. Sorry we were so quick.